Hi everyone, this is just a quick run through of the highlights of what me and Diana found out at ESHRE. Thought I'd do a quick presentation online because I'm not here for the next 2 weeks, and by the time I get back it won't be as fresh in my mind, and I know that we're very short staffed over the summer, so we may not be able to get a time when we're all together, and by September I'll definitely have forgotten it all. So I thought I'd just do a quick brief run through now. If there's anything that you want to know more about, then me and Diana do have the logins. You can watch the videos probably for the next few months, so yeah, just let us know. So one of the first things we went to was a debate between two people, and it was, should we transfer 0PN, 1PN and 3PN embryos? It was a bit of a meaningless debate really, because the person that was saying yes basically said, yes, we should transfer as long as we can test them. And the person that said no was saying, no, let's not transfer unless we test them. So they were kind of both on the same side, which was a little bit frustrating. But they did bring up quite good points. This slide here was about the 0PN zygotes, and they were saying that mainly the 0PNs are, most of them are from IVF, and that we've just missed the pronuclei. And the pregnancy rate from these 0PNs, the live birth rate, was 37.2% versus 40.6% for 2PN oocytes. So it's quite, it's pretty much the same. And they were saying that 95.1% of all 0PN embryos are diploid. So should we even bother testing those really? And when these embryos were subjected to ploidy testing, it was found that the pregnancy rate for the ones that weren't tested was exactly the same as the pregnancy rate for the ones that were tested, and just put back the ones that had normal ploidy. So there is an argument for just if they make it a blastocyst, then we should just transfer them without the need for testing them. Also, getting back to 0PNs, they were saying that if you did ESHRE and you put the egg straight into a time-lapse incubator, and you get a true 0PN, the chances of that actually becoming a blastocyst are pretty negligible. It just hardly ever happens. So it's quite rare to have a 0PN from ESHRE. So mainly all the 0PNs we're talking about are from IVF. Moving on to 1PNs. So 1PNs generally have a 12% chance of making it to a blastocyst because they tend to have slower cleavage timings. And there was a recent study from 2025 which said that 1PN embryos have a 70.5% chance of being diploid, which is a bit higher than what we thought before. And of these embryos that are transferred, the 1PN embryos have a 29.1% chance of live birth rate, and compared to 2PN embryos, which have a 35.7% chance of live birth. So it's still a significantly good chance. And if these embryos are submitted for ploidy testing, then the pregnancy rate with the ones that are tested is higher, but there's still quite a good pregnancy rate and live birth rate for ones that aren't tested. So again, do we test, don't we test? That's all a debate really. So the conclusion so far is that transfer of blastocysts derived from 0PN zygotes can be considered, and also transfer of blastocysts derived from 1PN zygotes can be considered, because the rates of implantation, pregnancy rate and live birth rate approach those from 2PNs. Preference is always given to 1PNs with a larger PN than just one single PN, which is the normal size of a PN. Tends to be more like a 2PN embryo. And if available, PGTA technology appropriate for biparental diploidy assessment should be used. Interestingly, they said there is a difference between IVF and ESHRE, because similar live birth rates between 0PN blastocysts and 2PN blastocysts in patients undergoing IVF, and similar live birth rates between 1PN blastocysts and 2PN blastocysts in patients undergoing ESHRE. So that's quite interesting. Now moving on to 2.1, the there's not a lot of data out there for 2.1 embryos, but there have been babies born, there have been euploid embryos found, and the stats they were saying is that for 2.1 embryos, the chance of getting to a good quality blastocyst is slightly less, but if you do get a good quality blastocyst, it's most likely going to be diploid. So is it, should we put them back? For 3PN embryos, and most of the data out there includes 2.1 embryos with the 3PN embryos, so it's quite difficult to just look at 3PN on their own. But it does seem like the data is saying that 45% of 3PN embryos are diploid, but you don't know whether that's the 2.1 embryos side of it. So there's not much data out there. But actually speaking to Shannon at the conference, she was saying there was a case in CRGH where they had 5 proper 3PN embryos tested, and 3 of them came back euploid and diploid. So that's quite amazing. So there definitely are some that are okay, but we definitely do need to test them. So the conclusion they said about 3PN is a transfer of blastocysts derived from 3PN zygotes can only be considered if PGTA technology appropriate for biparental diploidy assessment is used, and they're encouraging people to do pilot studies. So the Istanbul Consensus 2025 recommendations is that we do our FERT checks between 16 and 17 hours, and that the use of the word 0PN shouldn't be used. It should instead be used PN not observed. 3PN clinical use of zygotes is not recommended, and cautious clinical use of 0PN, 1PN and 2.1 PN zygotes, combining blastocyst culture and, if available, PGTA technology for parental diploidy assessment. Following this debate, there was another group from Japan who presented their data on 2.1 embryos versus 2PN embryos, which was quite interesting. They looked at 514 2.1 embryos versus 2,231 2PN normally fertilised embryos. These are their results. So they found that 2.1 embryos had less of a chance of making it to blastocyst, 35% rather than 55%, and less of them made good quality blastocysts, 18% rather than 29%. And then looking at pregnancy rate, these numbers aren't massive, but they found that the clinical pregnancy rate for 2.1 was half of what it was for 2PN. Miscarriage rate was the same, and live birth rate again was half of what it was for a 2PN. But these numbers are quite small. We're looking at, for live birth rate, we're looking at 5 out of 31 rather than 148 out of 450. So the numbers for 2.1 is quite small, but also relevant. They also found, when looking at the chromosomal aneuploidy and ploidy analysis, that for 2.1 PN embryos, 25.9 of them came back euploid versus 35.8% of the 2PN. And if they look at ploidy status, 92.6% of the 2.1 embryos came back diploid, which is very similar to the 2PN. And the average age for all of these patients was 39. So their discussion was that 2.1 pronuclear embryos have a lower embryonic development and pregnancy potential than 2PN embryos. They also thought that, they looked and saw that the micro-PN, 80% of the micro-PNs come from the maternal pronuclei, which is quite interesting. And embryos with a small pronucleus less than 10 micrometers are likely diploid and show chromosomal characteristics distinct from those of 3PN embryos. So their conclusion was that 2.1 PN, if you have PGT, then obviously do that, and if it's diploid, have an embryo transfer. If there's no PGT available, then measure the pronuclear diameter. If it's less than 10 micrometers, then it's very likely to be diploid. If it's greater than 15 micrometers, then it's potentially triploid. So you could potentially transfer an embryo that's 2.1 if you think its micro-PN is less than 10 micrometers without testing. But obviously further validation is necessary from these results. In this session, there was another presentation, and it was called Incidence, Development and Ploidy of Abnormally Fertilised Oocyte Implications for Clinical Practice. And this did the ploidy results for different fertilisation. And they found that 99.9% of 2PNs were diploid. For 1PNs, it was 80% of 1PN embryos were diploid, but the number was only 20, so it's quite a small number. 2.1 PNs, they found that 93% were diploid and only 7% were triploid, but their number was only 15 again, so quite small numbers. And 3PN embryos, they found that 41% of them were diploid and 59% of them were triploid. Again, number was only 17, so not a massive number of embryos. And they looked at the number of abnormally fertilised oocytes which were made blastocysts and which were suitable for transfer. And they found that 2PN embryos, 43% were suitable for transfer. 1PN embryos, 15% were suitable for transfer. 2.1% PN embryos, 27% were suitable for transfer, and none were suitable for transfer for the 3 pronuclei. So these findings support the need to genetically test to identify any embryos that are transferable. Moving on from that subject now, we then went to another session all about rapid vitrification and warming techniques. And the first speaker, she was speaking about validation of rapid vitrification for human blastocysts. And she was looking at her results, and she found that the survival rate for rapid in non-PGT tested embryos was pretty similar to standard vitrification. But in the PGT tested group, the survival with rapid or ultra-rapid freezing and thawing was a little bit less. Rather worryingly, they did find that in the ultra-rapid freezing, there was quite a few embryos which had these dark sort of degenerate patches, more than the normal vitrification. And they suggested it might be because it takes longer for the vitrification media to actually get into the blastocyst. So they were saying, we need to have more data to find out what these patches are for, and maybe not suggest the ultra-rapid for the blastocysts just yet. Okay for eggs, but not blastocysts. Then looking at for the embryos that did survive the vitrification and warming, they looked at the re-expansion rate, and they found that the re-expansion rate after 4 hours was less for the ones that were vitrified rapidly compared to standard, but the full expansion after 24 hours was pretty similar, was the same, and hatching after 24 hours was similar. So it just takes them a little bit longer to re-expand if they've been vitrified ultra-fast. So their conclusions were that there's a similar post-warming total survival and 24-hour re-expansion rate, but they have lower fully intact survival, 4-hour re-expansion and top quality embryo rate, and the cell damage patches that you saw in those pictures, they're a little bit worrying. But this is, like I said, for blastocysts, not for eggs. The next speaker was looking at ultra-rapid versus normal vitrification for eggs and the subsequent development, and this was a lot more favourable for the ultra-rapid. This is a bit of a busy slide, but the survival rate was higher for ultra-rapid. The post-ICSI degenerate rate was much lower for ultra-rapid. The day 5 blastulation was higher for ultra-rapid. High-quality blastocysts was much higher for ultra-rapid. So generally, it does seem like a favourable thing to do. The next three talks were about warming, normal warming and ultra rapid warming, and all three of them basically said either the success rates are the same or slightly better with ultra rapid warming. So it's more of a thing about streamlining your lab work really, rather than making the pregnancy rate any better. But the first talk showed that the survival rate was 98% with conventional, and again 98% with ultra-fast, so that's exactly the same. In this study they looked at embryos which had been donated to research, and they warmed them either normally or ultra-rapidly, and then they attached them to these sort of plate, so they'd carry on growing up until day 10. And they found that for normal multi-step warming protocol, 50% of the embryos went on to attach and grow to day 10. And in the ultra-rapid, then they found that 57%, which is very similar, really. The second speaker that was talking about warming, they did a very similar thing. They looked at the re-expansion rate after 2 hours and after 4 hours with the ultra-fast versus the conventional, and found that it was exactly the same, pretty much. And looking at the overall outcomes, they found that the positive pregnancy test was slightly higher in the ultra-fast. Clinical pregnancy rate was slightly higher in the ultra-fast, and the live birth rate was slightly higher in the ultra-fast, which is all leads us to think maybe we should be doing that for everybody. They also looked at the same thing for cases where the blastocysts had been tested to see whether they were euploid, and again similar results, slightly higher in the ultra-fast warming. Again, another study saying the same thing really, that comparing ultra-fast and normal thawing protocols, survival rate the same, pregnancy rate the same, clinical pregnancy rate the same, miscarriage rate slightly less with ultra-fast, all saying the same thing. And then looking at the embryology data from eggs that were warmed with both techniques, it's all very similar. Similar survival rate, similar fertilization rate. So it looks like it could be very beneficial to go to the ultra fast moving forward. The next session we went to was a bit different. It was all about the advances in vitro maturation, rescue ICSI, biopsy and embryo selection. The first talk in this session was by a woman who was comparing 3 different ways of biopsy. She was comparing the laser pull technique, the laser flick technique, and a new technique called the cut flick technique, which they used a special holding pipette which had a very sharp edge, where you would flick the embryo like you would with the laser flick, but without using a laser, because the holding pipette makes the cut for you, and looked at the apoptosis rate, the size of the biopsy, everything, to see if anything made a difference. And they basically found that there was no difference in all 3 techniques. So it doesn't matter how many lasers you throw at that embryo, it doesn't make any difference to the apoptosis, necrosis, or the diagnosis. That was all for that one. The second presentation in this session was by a group from Vietnam who were looking at the outcomes after hatching on day 3 and then leaving the embryo to grow to day 5 and biopsy, and hatching on day 5 and biopsying straight away. So they were comparing the 2, which is quite interesting. So these are their results for female, basically the demographics for both groups. They had 224 in the hatching day 3 group and 267 in the hatching on day 5 group. In both groups, the fertilisation rate was the same. Good quality blastocysts was slightly higher in the embryos that were biopsied on day 3, and the blastocysts biopsied were pretty similar between both groups. So then they looked at the embryo chromosomal status, which was pretty much the same for both groups, as you'd expect, but the clinical outcomes were better for the protocol 1, the hatching on day 3 group, 83% beta-HCG compared to 66.4%, and the ongoing pregnancy rate, again, 10% higher in the patients who were hatched on day 3 rather than hatched on day 5, which is interesting. The next presentation we went to was from a lady in Other News who was looking at evaluating the role of rescue in vitro maturation and rescue ICSI in ART, a systematic review and meta-analysis of outcomes in low failed maturation fertilisation cases. And basically they were looking at, for the first part, the in vitro maturation, they were looking at injecting M1s that turn to M2s on with less than 6 hours versus ones that are more than 6 hours, it takes overnight to mature, versus GVs, and they found that the blastulation rate is lower, but the euploidy rate is the same if you do get a blastocyst from these later embryos. So it's definitely worth doing late injection if that's all that you have. This slide is very complicated, so I won't really go into that now. But basically, if you inject metaphase 1 that turns to metaphase 2 within 6 hours, then it's better than if you leave it overnight, and better than if you have a GV, which we all kind of know already. Fertilisation rate is lower in these matured eggs. Blastulation rate is lower. Clinical pregnancy rate is lower. But the euploid, if you find that the embryos are euploid, then the clinical pregnancy rate is similar. So in conclusion, for each M1 after 6 hours incubation, I had 36% maturation rate, 35% fertilisation rate, and 35% blastulation rate. So they're saying for each M1 oocyte has a 7% chance of forming a blastocyst, which is not massively high, but better than nothing. She then went on to talk about rescue ICSI. Now, their rescue ICSI is different to our rescue ICSI. What they do, which seems very long-winded, they inseminate, and then 5 or 6 hours later, after they inseminate, they denude all the cells off the eggs and see if there's a second polar body. And if there isn't, they will then do ICSI. So, I mean, in our case, you'd be doing ICSI at 5, 6 o'clock at night. All seems a bit strange, really. But they found out that the 2PN rate is the same for this rather than normal ICSI. They found everything was the same apart from the 3PN rate was slightly higher in this rescue ICSI group, which you would imagine because there would be time when they had fertilised, they just hadn't extruded a second polar body for whatever reason, or you missed the second polar body and then you injected a sperm into the egg. So this was all a bit of an odd thing to do, really. Anyway, this is what they clearly are doing at Other News. We went to a different session a bit later, which was more to do with what was going on inside the blastocyst. So they're looking at cytoplasmic strings, or as Ben likes to call them, Philippodia. And there were a few presentations on that, all saying that the presence of these cytoplasmic strings is beneficial. So these are some results here from one of the clinics, which was showing the pregnancy rate. The blue is for the cytoplasmic strings, and the green is without. So blastocysts that show these strings have a higher pregnancy rate, much higher pregnancy rate abortion rate lower and full-term pregnancy rate is much higher. So maybe it's something that we should look out for. And if a blastocyst does have these strings, then see it as a very positive benefit. Yeah, so this was their conclusion. Blastocysts with cytoplasmic strings are associated with higher implantation rates after transfer. This effect remains significant even after adjusting for oocyte age and embryo quality, and it actually outperforms both as a predictor of implantation success. And under equal conditions, blastocysts with cytoplasmic strings have more than twice the chance of implanting compared to those without. There was also a lot of talk about AI and how they can predict an embryo or an egg becoming a blastocyst. And one of the ones, I think there were about 4 or 5 presentations on it, was something called Magenta, which takes a look at the egg from static photos, and you input the patient age and BMI, and then it sort of looks at perivitline space, zona, and all the different things you'd see inside an egg, and then gives it a predictive value between 1 and 10 of whether that egg is going to make a blastocyst. So, like I said, there are loads of studies with big numbers saying there does seem to be a correlation, but it doesn't take into account any of the sperm parameters or the sperm facts. So it's only meaningful up to a certain extent. And I think realistically, if you're a good embryologist, you can probably look at an egg and predict whether it's going to make a blastocyst anyway. So, didn't really get that one, but there was a lot of talk about it. The last slide I'm going to talk about is there was a guy from Mexico who who basically was looking at pregnancy rate and figures from patients whose eggs, basically all of day one was done by automation, so robots, so automated sperm prep, automated egg collection, and automated denudation of the eggs, and automated ICSI. So there was no embryologist involved at all. It was all done by robots, and it was quite freaky, really. And these are his results. They so for the automated fertilization rate, if you look at the top, you'll see that 80% fertilization rate for automated rather than manual, 100%. Second patient, 43% versus 60%. So, it's clearly not as good as the human. It's just quite interesting to see. And they've had 2 live births already and 1 ongoing. You can see some of the cases at the bottom, like number 9, fertilization rate was 0 for the automated versus 100% for the manual. So that obviously it's got a lot of that needs to happen before this can go. This can be used for the majority of cases. But it was quite interesting to see where our profession may be in 10 years' time. We may not have jobs. And that's it, really. If you want to know any more information on any of it, then I'll be back in a couple of weeks. Or, like I said, we can give you the info and you can watch the presentations yourself. There was loads of presentations we didn't get a chance to go and have a look at. But we had a great time, and Diana's there as well. She can help with anything that you're not sure of. So sorry that this has been 30 minutes out of your life, but hopefully it will have helped. Thanks. Bye. See you when I get back from Mexico.